See, I guess we had Doctors Atkinson and Rubel to respond, but and they could please come up. But I also want to open this up more generally to all the speakers. Yeah. But I guess so. I'll just ask you. But while you're getting set, do we still have any of our friends on these remote sites available? Can you just check in here? Anybody at Duke there? Okay. And what about Wichita? Duke's there. Okay, Wichita. And at the Ethics Center here in Missouri? Looks like not, but okay. All right. Well, yes. So, Barbara, do you?
I had something I wanted to answer,
Yes.
a question from earlier.
Okay.
I actually got an answer to the question about whether our states have any rules protecting privacy over and above what the national law is. And just to remind you, it was mentioned earlier, there's a national law called GINA, the Genetic Information Non-Disclosure Act, and every state has that as the current base. Kansas has no other laws protecting genetic data over and above that. Missouri has a little bit of protection. They have a law that actually says that requires a person who has access to genetic information in their business, i.e. your doctor or researcher, to keep that information confidential without a release from the patient. So there's a little bit of additional protection. Neither state has any law against surreptitious use of genetic material, which is something that several states now have. That means that we could take your Coke can from lunch today and find out your genetic information without any consent from you. Anybody can do that over and above law enforcement people. So there's no protections like that in Kansas or Missouri.
If you watch the police shows on TV, Law and Order, that's often
they do it all the time.
They do it all the time.
It's probably giving other people
incriminating evidence,
right? The idea that they might be able to do it as well.
Right, so. Right. I guess, Alan, I wanted to take advantage of your legal background here and just ask: are you aware of any gaps in the law that need to be that we should be paying attention to that would actually help us here in terms of protection of patients, privacy, and other patient protections?
Right. Well, obviously, whatever gaps I see are going to be peculiar to my views of what's important. But I think that what Barbara just mentioned about surreptitious use of genetic material is actually probably one of the biggest ones, given that one of the primary concerns that Misha raised and I raised, other people have raised, is about use of such material for discriminatory or unfair purposes. And there's not necessarily a need to get information that's disclosed in a medical context to get. Barbara mentioned it might be possible to do that sort of freelance. I would think that's probably the first and most clearest case.
Okay. All right. Any questions about, really for any of the speakers or who talked this afternoon or anything that we've actually talked about so far today?
I have a question for the translational folks who just went. This is outside of my bailiwick, but I do have some familiarity with public health surveillance and public health information gathering and public health research. And I know that the distinction between public health practice and public health research is particularly problematic, given that lots of stuff that's typically called public health practice looks a lot like research. That is, information gathering about foodborne illness outbreaks and so forth is going and gathering information and not subject to common rule protections, but then other stuff is indeed subject to those kinds of protections. I was wondering if any of the stuff in the comparative effectiveness research or translational research or the worry about the worries expressed in the previous presentations had drawn on any of that kind of controversy or that pushback against distinguishing between, clinical versus research, clinical practice versus research in the public health context.
Lauren or Rick, did you?
Yeah, it's not totally on, but I'm not sure that there's a lot difference than the distinction we sometimes make between quality improvement and research in the hospitals, the same sort of situation of practice versus research, and how and when is that defined?
Right. Yeah. So I'd like to ask a specific question. Oh, is there's... No? Somebody have a question? Oh, yeah, over here on this side of the room. But I'm also going to tee up a question for John and Mikhail and Sarah. Yes.
My question has to do with how the program evaluation fits into all this. Taking off the public health sort of discussion, quality improvement, research have clear goals, but we also have this program evaluation sort of systematic inquiry. Where does that fit into all this?
Anybody want to tackle that? Sarah? Yeah, we can. Thank you, Alan.
I think it depends on what you mean, I guess, by program evaluation, which takes place that's a very broad term, and comparative effectiveness research is essentially a kind of program evaluation. So I would say that any of the considerations that we're talking about in this context of learning healthcare systems, or QI, also applies to program evaluation as well.
All right. Yes.
So a lot of the problem, I think, comes back to the curious categories that the Belmont report used to try to define research, which was not based at all on risk, but was based on intention. So it's research if you intend to test a hypothesis or create generalizable knowledge. It's not research if you don't. And so the fudge words in there are, what's generalizable knowledge? But the substantive issue is, why should that be the criteria that's thought of as creating risk? And I think it gets back to the idea that people who are trying to create generalizable knowledge are somehow willing and even eager to override the rights and safety of individuals because they're so single-mindedly focused on this goal of creating generalizable knowledge. So what it leads to is program evaluation and quality improvement and learning healthcare systems are all obviously testing hypotheses and creating generalized knowledge, but we just sort of say, oh, well, they're different. So QI, no, that doesn't have to go to the IRB. Well, why not, and what is it? And if you were actually trying to learn something by doing it, would that then make it research? And if so, why? The alternative is to look at risk, which makes more sense, I think, but is not what guides our current.
That is what we're doing. It seems to me that is what we're doing. I mean, we just recently completed a submission for a research project that had virtually no risk to it at all. It was just a collection of data from hospitals, basically. And the frustration that I had with it was we knew that we had to go through the IRB to do this exempt thing that you talked about earlier, simply because if it were ever going to be published, the first question we were going to get asked was, who is your IRB? And I wanted to say, I don't care that they ask us that, but the researchers who were involved in the study said, if we don't do this, we're
And get it published.
we're at risk of not being able to get our data published. And which is, I think, back to your point about how screwed up is that? It's upside down. But I do think that intention does matter. I mean, it does affect. I mean, if I want protection from somebody who is intending to study me, if I don't know who that person is or what their intention is,
Yeah.
If they're trying
you weren't saying intention doesn't matter, right? But
it shouldn't be the only criteria.
Yeah.
I think so, Dad.
So you're saying that if you're in a hospital where they have put a quality improvement project in place, encouraging all the employees to wash their hands before they touch you, and they are collecting data on hospital-acquired infections, you want to know that. Whereas if they just had a policy that all employees should wash their hands, but they had no intention of studying whether it was beneficial, you don't care.
I'm going to assume that the EBR has already been done on it. If the policy is in place, I'm assuming that somebody's determined that, which I think was your question about you can't really necessarily assume that with a clinician because the clinician hasn't necessarily done the research to find out whether what suggesting to you is really in the best practice. I get that. I'm just saying, my question is more around if the doctor is incentivized, and I don't know it, to do something to me, either through assigning me a medicine or a procedure or something, and I don't know that, the intention of that doctor, it happens all the time. In palliative care,
What happens all the time?
We do battery on people at the end of life.
Yeah.
Because the system incentivizes the entire system.
But it's not research, so that's okay.
No, I agree with you. But I'm saying, but we should be studying that.
Yeah. No, I mean, John, you weren't here for my presentation this afternoon, but that was one of the points I made, that I think that one of the ironies, and I know you've made this point as well, that there are clinical things that we call routine clinical care that are much riskier than research. So I actually wanted to bring this back to a point. I was reading one of McKell's papers, which they had evaluated practices around the treatment of hyperglycemia after myocardial infarction, after heart attacks, and had found that there's tremendous variability in hospitals about insulin usage and hyperglycemia management, and concluded that there needed to be a clinical trial because there's so much variability in these practices around a range of usage of insulin. So seems to me, so my question then is the trial being proposed, this is kind of comparative effectiveness research, you could think of it in that way, and what kind of oversight should that research get? I mean, you would presumably propose randomizing hospitals or subjects or whatever it's actually replicate some of the issues in the support trial, right? Because you would presumably randomize across a range of what is now normally accepted clinical practice. And just as you raised, Sarah, does just the fact that you are proposing to randomize, does that make this less than minimal risk? Or does it? And how much of a burden does this impose on research, and how much of a barrier is this to doing these kinds of studies? So you want to speak to that, and John and Sarah, if you could respond to what he says.
Yeah, no, great question. So the problem with what we showed in the article was that there was a huge amount of, as you mentioned, huge amount of variability, and our hypothesis was, which I personally think is there are many reasons why that is, but essentially what we showed was if you there is a statistical way to essentially examine how likely two identical patients, if these two identical patients with the same clinical characteristics present to two different hospitals, how likely it is that they're going to be treated the same or treated differently. And in that particular clinical scenario, there was a very high chance that they're going to be treated differently based simply on which hospitals they went to, independent of who they were or what conditions they presented with. And the reason for that was that, the only things that the few studies that have been done in that particular field are very conflicting, and the doctors don't really know what the right thing to do is. And that's a perfect situation where you should do a clinical trial to figure out what it is. Which part of which type of treatment actually improves outcomes and which does not, or could be even harmful. So those efforts are underway, but the question is if you were to do a clinical trial like that, because we don't know what the right thing to do is, and there are, the standard of care truly doesn't exist because everybody is doing whatever they think is right, would it be ethical to randomize patients without informed consent to the two types of treatments, which would be either managing it more aggressively or less aggressively, and see what happens? Because patients may get this treatment just based on which hospitals they go to today without any research being involved.
Right.
And I think there is some credence to say that since we don't know what's safe and what's not safe, and what's beneficial and what's not, there's a case to be made that this could be done. Right. I think from an IRB standpoint, they would have really hard time. I know they would have really hard time. In fact, they would not approve a randomized clinical trial, at least at our institution, without informed consent, because they would perceive current guideline recommendations as a standard of care, even though those guideline recommendations are based on expert opinion and not very much data. And one could argue that the expert opinion of one expert versus if you collected a different group of people making guidelines in different institutions, they would come up with very different guidelines based on their expert opinion. But regardless of that, I think that's what the issue would be. I think it's a very reasonable argument.
And I guess the other question, though, is how much of an impediment is it to getting this kind of research done to go through the IRB approval?
Well, it's huge.
No, I mean, this is a rhetorical question.
It's a huge impairment, and of course, in that particular example, this would need to be a multi-center clinical trial involving multiple IRBs. In today's environment, there is no way that it would ever get off the ground if you try to do it without informed consent. But it means huge difference in time on how quickly you'd be able to recruit patients, how quickly you'd be able to complete a study, and how much a study would cost. I mean, we've talked about the fact that how expensive randomized clinical trials are, and the fact that with all their shortcomings, they're still the gold standard for many clinical questions. And one of the reasons we don't do as many trials, I guess some could argue that we do too many, but I think we don't do enough. In many reasons, probably the main reason for that, or the two main reasons for that, is that they're becoming more and more expensive, and part of that expense is that there is more and more regulation, some of which is necessary, but some of which I think is detrimental, actually.
John or Sarah, do you want to respond to?
I think a better question to ask than do you need consent or do you need IRB review is what kind of consent and what kind of outside review. So the idea of having studies be presented to uninvolved, objective, knowledgeable people, knowledgeable about the science and knowledgeable about study design, I think is crucial to designing good studies. And good studies mean studies that address an important question where there's genuine uncertainty in the research community and are designed in such a way that they will likely answer the question with as little risk as possible to study subjects. Consent can mean many things too. So there was actually a great example, which I'm sure you saw in the New England Journal about 2 or 3 weeks ago, a study they did in Sweden, where the question was, when somebody comes in with an acute myocardial infarction, is it better to just do the, I don't know enough cardiology, do the angioplasty, put in the stent, or is it better to go in and suck out the thrombus that's blocking the artery first. And there was big disagreement among experts, some suggestive retrospective studies that sucking out the thrombus was a good idea and improved outcomes, but lots of people disagreed. And the only way you could do that study is when people are coming in with their crushing chest pain to randomize them to either get the thrombus out or not. So how did they get consent? They did a brief oral consent. They didn't say what that consisted of. I would love to see the script for that as someone's in there having their heart attack. Based on that, they randomized people, then went back within the next 24 hours with a full consent after they'd stabilized the patient. And at that point, they were already randomized to the intervention, but they could say, no, I don't want to be in this study, and they wouldn't get any of the follow-up, and their data would be taken out of the study data set. Although in Sweden, all coronary centers are part of a national database as well, so they had all the data for people who were in the study, randomized, and who were not in the study, and who got either one treatment or the other. And they managed to do the whole study and recruit 10,000 patients in 2 years for a couple $1 million. So there are, and their IRBs approved them. I don't know if ours would. So what should the outside review look like? What should the consent look like? There are different ways of doing it than the way we do it now that are still, I think, very consistent with the Belmont principles of respect for persons, beneficence, and justice.
Just to add to John's point about that particular trial, there was one other feature of the trials that was very innovative, which it was what's called a randomized registry trial. It was done in Sweden, and so they randomized patients, but all the follow-up was done through the national registry. And so not only because of that was they able, because of the consent procedures they used, not only were they able to recruit patients a lot faster than a typical clinical trial, but the trial also cost less than 1/10 of a typical clinical trial, what it would cost normally. So it was done a lot faster and dramatically cheaper to answer very important clinical questions than what you'd see on average.
There was 100% patient follow-up? Is that what you said?
Because if it was all in the national registry, yes.
Could pioneers help with that?
Huh?
Could pioneers actually help? I mean, if you had 10,000 cardiac patients in Kansas City region, well, I don't know how many there are, and they all consented once they said, yes, I have heart disease, I will consent to any research that's coming down the pike for me, and you couldn't do that.
Yeah. Lauren, what do you want to?
Yes.
Well, no, I don't think so. It wouldn't quite work that way because, first of all, our data in pioneers in the community is self-report of history. It's not real time what's going on with their health care. And then it's just saying, yes, you can contact me, but the individual has the right to review and decide on every single study. It is not giving carte blanche approval to participate in all studies. So it's very different. Our registry is simply about enthusiasm for potentially participating in research, but it's not gathering the data. And then, like I say, only the ones that then additionally give us access to their electronic health record, which right now we only have set up to access KUs. So if they're not a KU patient, who they easily could be in the Pioneers registry, but we wouldn't have access to their health records in that regard. My question, though, about that national, and because I'm not familiar with the Scandinavian approach in their national registry, is while the data are there, the data are entered by a lot of different people or providers, so where is the standardization of the actual data that's being collected? One provider may be recording all sorts of issues or symptoms or whatever, but another provider might not.
Right, so I'll answer in two parts. First is, I don't live in Sweden, so I can't tell you exactly how they do it, even though I have many friends there that I work with. And they've had it for decades, and so the data fidelity has been distilled over time for sure. But I think my understanding, speaking with them in terms of how the data works, is very similar to what ACC and CDR registry looks like here in this country, which is that you have data being collected for numerous hospitals, and how to ensure, because one hospital could do a great job putting that data in, and one person, hospital could hire somebody who really doesn't care what the data looks like, just enter some random stuff because they want to get home early. I mean, just to take extreme examples here. And, the way that this works is that all the data fields are the same across hospitals. So, and the way ACC and CDR works, for example, is you enter, the way your electronic health record is configured to work with the registry is that the stuff that you'd normally enter anyway in your medical record as a part of the procedure then automatically populates the fields in a registry. And so there is no major duplication of effort. And then all the fields from all the hospitals for the registry are the same. So you don't get a choice of, what units, for example, you're going to use for, I don't know, creatinine, because it's already pre-populated. So, you enter the value, and then on the back end, in the ACC and CDR, data vault, there are people who are sitting there and doing data cleaning and preparing data for analysis, who have specific set of data checks that they go through. So if somebody enters creatinine of 505, which cannot possibly happen, that would be, typically caught and fixed, and there would be a follow-up.
Yeah. So they have methods of data to check the integrity of the data.
It's not a perfect system.
Quality.
No system is, right. But it's not bad.
Barbara, did you want to comment?
Well, I have a couple other topics from the commission. So if somebody wants to follow up on this.
Anybody want? Sarah, did you want to say anything more about? Do we have some people who sit on IRBs here, and I'm just wondering if anybody who's sitting on IRB have any comments on what we've been talking about? Okay, but Sarah, did
So I just wanted to add, I wholeheartedly agree with John's point about the question really is what's the nature of consent. I think one of the issues that's going to come up, which is really much more of a practical issue, as we blend QI, research, and care much more closely, is that IRBs are going to become potentially overwhelmed with determining what should be examined and reviewing all these studies. But there does need to be some oversight of QI stuff or this kind of learning activity stuff to make sure that it's high quality and that people are being consented properly. And I also just wanted to point out, related to that in an early issue of the Hastings report, Emily Largent and Steve Jaffe had a very intriguing where they did a sort of a thought exercise and laid out a kind of a learning health system and talked about ways of organizing consent, which would be, some of the consent would be up front, that if you, which is along the lines of these registries, that if you are in this health system, you consent to be part of studies that would be low risk, but it's still determined by the extent of risk, if it's low or high.
And Roswell Park IRB experience? Okay.
So we actually had two review committees, a scientific review committee, which was pretty much as you described it. There weren't laymen on the scientific review committee. So that includes scientists, clinicians who were clinical scientists. Then the IRB, you have to have a layman on the IRB, is my understanding, which usually worked, but it could be very problematic, because if people don't understand what you said that you needed to understand to really assess research, if they don't understand the research, then they really can't address the issues surrounding the research. So we had two committees you had to go through. I avoided the IRB. I like this scientific review committee, but the scientific review committee was a very good committee, and the research was assessed in a very critical way, and lots of good advice was obtained for researchers.
Yeah, I know many institutions that have similar, and that in theory works well. What some investigators have experienced, this one included, is that it it does tend to just slow the process a little more, because even though the scientific review committee reviews for the science, and the IRB will invariably review for the science too, because that's part of evaluating the risk, is how, is the science good enough to subject this individual to this risk. So yeah, it's complicated. Good discussion. We have a few more minutes left in this section, so Barbara?
All right, if we have time. I don't have any answers to these questions, but these are two more issues that came up in several of our studies and I thought might be interesting for you all to think about. One of them is cost. That's been touched on a couple times here, but I'm thinking particularly of when public health sort of comes up against individual patients, and that's in studies like how often, or when recommendations come out from major public health groups about when the first mammogram should be given to women, or how often pap smears should be done. And there's always data that's public health data that says it's not cost effective to do it too soon, do it too often, do it whatever. But if it's individual patients, it's a very different consideration. And it's very much a consideration of who can afford to pay for it. And when it's the general public paying for it, maybe we can't afford it as a general public. So I just raised that as an issue that's come up in a lot of different circumstances. And the other one is who gets the benefit of the research. Right now, pharmaceutical research, a lot of it's happening overseas. And it's happening in populations who may not have appropriate health care in their own country, but they may be offered health care for AIDS, for instance, in an AIDS study in Africa. And will they ever then get the benefit of what comes out of that research? And in a more subtle way, it happens in the United States too, where you have disadvantaged populations who are often the people who may be necessary to use for certain kinds of research, but then what do we do as a population to be sure that everybody gets the benefit of that research? And I think that kind of subtle discrimination is a real issue too. And I just raise those as sort of corollary issues to think about.
Oh, and I assume no. Oh, good. Is it directed to a particular person?
It might be more directed to Mark, but not necessarily specifically. It goes back. Duke just wanted to know what role IRB plays in using big data.
Generally, it's just in determining which projects are exempt or not. So if the data is de-identified to an appropriate extent, then the IRB can issue an exemption. So I think that's, it's a situational thing. And that's kind of the threshold that they're involved in.
Great. Well, thank you. We're coming to a close. Thank you. So actually, Alan, I'll ask you to get up, and I'll ask if Jim Sprigarelli, if you could come forward. We thought as we closed